darles la
I
bienvenida
have
al
the immense pleasure to welcome you to the webinar on addictions to sex, internet, and drugs. Our distinguished guest is the New York expert, Liz Lacy.
Without further ado, I would like to give the floor to Liz Lacy. Please enjoy the webinar, and we will meet again in a while for the Q&A session. See you.
Hey everyone, I'm going to just share my screen. So hang on one sec. And I think we're good here. Aha! And we did it. All right. So I am Liz Lacy. I won't I won't give any more introduction to myself, except to say I am thrilled to be here. Particularly for the Argentinian American Schema Institute, which is I hold in very high esteem. Patricia is really very interested in evidence-based models and is great at really staying in alignment with the science and making sure that anyone who leaves her institute really understands and has the skills necessary to be excellent schema therapists. So I highly recommend the institute. And so I am very, very passionate about this topic. For anyone who knows me, the minute you have me talking about addictions, you know, I could go on forever, but we only have a short time together. So I'm going to jump right into it. So first, I really want to talk about the therapist's own experience in working with this population. If any of you, and I would imagine most of you, are already working with people who have addictive disorders, you already know what your emotional experience is like, right? So there are times where we as therapists can feel demoralized, we can feel hopeless, right? We can feel the anger and frustration at working with someone whom we care about, where we keep going, oh, it feels like we're on a hamster wheel. We keep going over the same thing. It feels like over and over again, and they keep doing the same thing over and over again when we can't help the patient get traction. So you've all had, I'm sure, some of these experiences. Hopelessness, right? The urge to rescue, especially if you have someone who presents with a lot of trauma history or becomes suicidal when they're using their substance or behavior. The urge to transfer the case. I don't know about you, but I know many clinicians will start to think, you know what? I think this person isn't in the right level of care, and we need to start thinking about transferring him or her to someone else, right? When we know it's just our frustration and we're just tired of seeing the same thing in every session. We can become critical of the patient, right? We can feel our own critic come out because of things the patient's doing, or some of them, you know, we'll talk about the modes that show up a lot. I saw in some of the questions, you know, issues around patients lying to us, minimizing, not showing up. We can get so worked up and activated ourselves, we start to become critical, or we can become critical of ourselves. Like, I don't know what to do with this person. Like I've tried everything I know, and the same thing keeps happening. We lose focus. These are folks who, first off, right? Well, the literature tells us 2/3 of this population, whether it's behavioral or chemical, also have co-occurring personality disorders. So when you have addictive disorders with personality disorders, people are coming in crisis often, right? They're coming in with their hair on fire. There's family arguments are going on. There's a lot of chaos. It's very hard to stay focused on treatment. And finally, we can become very detached after a while, right? It feels like we're not getting through. The patient is in a detached mode, and before long, we become in detached modes. There's not one feeling on this list that I haven't experienced myself. I have felt every one of these things. And I don't mean at the beginning of my career. I mean, there are times where, for example, the patient who he has I'll tell you what I mean by this, but a partial fusion addiction between alcohol and bondage, sexual bondage. That's his combination. And he also has horrible trauma, sexual trauma, other kinds of trauma. And he goes into these states where he will pay dominatrixes to financially blackmail him. He'll actually give his social security numbers, all of his personal information, and he will get into a cycle where this happens. After a while, I can't tell you how many times I'll start to feel like this is hopeless. Like this is never going to change. I'm starting to feel what the patient feels, right? And I'm going to say the primary reasons these things get activated in us is because we've lost focus on the conceptualization of what is actually going on for the patient, right? And we don't really understand the origin of addictive disorders, because if we truly knew and understood the complexity, like we do with borderline personality disorder, we wouldn't be expecting, oh, recovery is going to be a straight line, or, well, there'll be a few relapses, but it's not, right? It's not going to be this chronic, entrenched disease. We say we know it is, but do we truly treat it like it is, right? Scott Kellogg, I know Patricia mentioned Scott. Scott and I have frequently spoken about what happens in addiction treatment, which is there is a covert judgment that goes on with people with addictive disorders. We have to ask ourselves, are we treating sick people or bad people, right? The system of treatment, the system, our forensic system tends to be very, very punitive with addicts. And I'll tell you, as I go over this, you'll see why that's absolutely the worst system for addictive disorders. If we could have designed a system to create addictive disorders, this is the one we would have designed. So today, in the next hour, I'll do a quick schema therapy review, or not very intensive. I'm assuming most of you really understand schema therapy, but we'll just talk about it in terms of how it applies today, the 4 keys for effective work, of which, if we don't use them, we're dead in the water, really, with people with addictions, what a case conceptualization is like, complete with a mode map, a very simple, I think, easy to understand mode map, and understanding what is going on in every addictive patient. And really talking about how do we effectively do empathic confrontation, particularly with what I call a colluding or enabling mode, which we'll see in the mode map. Okay, so very briefly, we know in schema therapy, in terms of theory, and of course, much of this, as Patricia pointed out, is based in evidence. Child comes into the world, begins to develop, has adults around them, hopefully has adults around them, certainly has people and an environment around them, has core developmental emotional needs, like safety and validation and healthy limits and autonomy, etc. And when those needs are not met to a larger or smaller extent, especially over time, and they have repeated experiences where those needs are frustrated, they begin to develop schemas, right? Shorthand ways of understanding themselves, others, the environment, right? Complete with emotion, right? Jeff Young has outlined for now 18 maladaptive schemas that affect us. And because of the pain generated by these schemas, the individual develops coping modes for the schemas, right? And in terms of the 3 primary categories of coping modes, we have compliant surrender, an overcompensation mode, and a detached protector mode. And of course, we've got many that would fit under one category or another. When we're looking at the pure addictive mode, we're looking at under the detached protectors, right? It's all designed to dampen and change feelings, to shut it all down. Okay, so we'll talk about our definitions for a minute. This is my definition, and I'd say if you look at your addictive patients, and if you're trying to help them understand what is an addiction, like what is a problem behavior, really we're looking about impact. So a behavior or a substance that provides temporary relief of emotional pain, and despite negative impact, despite repeated negative impact, they continue to use that substance or behavior to relieve the emotional pain. And it's always joined by a craving to continue to use that substance or behavior, right? Now, that can go from, on a continuum, from abusing the substances or the behaviors all the way to very intensive, very complex dependence, right? When you're doing your assessments, you absolutely will need to assess for other addictive disorders that may be surrounding the primary addiction. You have to, of course, you're assessing for what is the primary addiction. It's not always clear. Some addictive disorders have what's called a fusion dependence. A fusion dependence is when you have, let's say, here at least in New York, we have something called a chemsex addiction problem. So methamphetamine is fused with sex, right? Primarily anonymous sex, sexual hookups, things like that. But one thing always goes with the other. The sex always goes with the methamphetamine, vice versa, right? When you have a fusion dependence, they have to be treated at the same time, right? I don't recommend treating 5 different addictive disorders at the same time. We're usually going to pick the one that really affects the person the most. But if it's fusion, we need to do them both. Sometimes there's partial fusion, meaning that they often go together, but they can sometimes come apart. And then, of course, addictions that really one has nothing to do with the other. They just have several different addictive behaviors. Behaviors can be both behavioral addictions and chemical addictions, right? So behavioral addictions are going to be things like gambling, sex. Chemical, of course, are going to be drugs, alcohol. Okay, internet would fall under behavioral addiction. Okay. So the 4 keys to working with addictive disorders, right? Again, without these elements, we're dead in the water. Okay. All have to be there. Number 1, the therapeutic relationship. 2, we do a 3-part assessment, right? We're going to go over each one of these. Conceptualization of the problem and the client's particular mode cycle, right? And empathically confronting colluding modes.